In association with Mindray, it gives me an immense pleasure to welcome you all for our third online webinar session, Female Genital System Pathology. For any pathology department, female genital system form the major bulk of the cases we deal in our routine work. And having a good knowledge of the system help us in building a good pathology practice. We are excited to have national and international renowned pathologists to talk in this saga. This will be a prologue for our upcoming 89th IAPM chapter meeting, scheduled on Sunday, 28th August 2022, where FTS is the slide seminar topic. It is my honor and privilege to welcome our distinguished speakers, Dr. Diana, Senior Consultant Pathology, National University Hospital, Singapore, Dr. Santosh Menon, Professor of Pathology, TMH Mumbai, Dr. Bharat Regi, Professor of Pathology, TMH Mumbai, Dr. Mmr Ihc, Senior Consultant Pathology, KK Women's and Children's Hospital, Singapore, Dr. Radhika Srinivasan, Professor of Pathology, PGI Chandigarh, Dr. Kedar Diodar, Professor of Pathology, TMH Mumbai, and Dr. Sandeep Mathur, Professor of Pathology, All India Institute of Medical Science, New Delhi, who will be with us for the next 2 days to share their vast knowledge and experience. I also like to take this opportunity to welcome our esteemed moderator for each sessions who have kindly agreed to share the sessions. And I like to welcome and thank Mindray team for providing us this platform to conduct this academic session. And last but not the least, the chapter invites all its members, consultant pathologists, and postgraduates across the country to be a part of this webinar. Now, I welcome Dr. Rajan Ji, President, IAPM Kerala chapter, for the presidential address. Over to you, sir.
Respected guest speakers, chapter members who has given willingness to moderate the various sessions, my colleagues, pathologists across India, and my dear postgraduates. This is the third webinar we IAPM Kerala chapter is conducting. First was on lymphoma prior to our 87th chapter meeting, where our slide seminar topic was on lymph node pathology. The second webinar was on neuropathology prior to the 88th chapter meeting. Again, the slide seminar topic was on neuropathology. Indeed, it became a routine practice to conduct a webinar just before the chapter meeting, focusing on the slide seminar topic. This time, as you know, our 89th chapter meeting is on female genital tract pathology to be held on 28th August 2022. And remember that after 4 consecutive online stage meet, we are conducting an offline meeting this time, a physical meeting this time. The venue is Baby Memorial Hospital, Calicut. And I request all the chapter members to come for the stage meet and make it a grand success. As our secretary said that this time also we got some eminent faculty across country as well as international faculties are there who are actually contribute to these areas. And this coming to this evening and tomorrow evening there will be 4 sessions, and this evening there will be 3 sessions. And there is a slight change in the program schedule today. 7:30 to 8:30, it was Santosh Menon who was taking the mesenchymal tumors of the uterus, and this is postponed to the 3rd session. And the Santosh Menon topic lecture will start by 8:30 to 9:30, and 7:30 to 8:30 it is Bharat Regi who is actually presenting. So that is the program schedule. There is a slight change. Otherwise, there is no other major change in the program schedule. And this is the 3rd time we are collaborating with the Mindray India, and it's actually the backbone for any webinar that is conducted by IAPM Kerala chapter. Thanks to Mindray India for their extreme support, the technical support that is given for registration, everything. And I'm not standing in between you and the speakers, so we can start this program. And over to Dr. Ani Praveen, Secretary.
Thank you, sir. So without further delay, we'll start our first session of the day. And it is my pleasure to welcome my teacher, Dr. Ajit Namba, to introduce the first speaker. Sir was a former head of the Department of Pathology at Mmr Institute of Medical Science and currently serves the Director and Head of Advanced Center for Pathology and Lab Medicine, Carcinoma Health Center, Kochi. Over to you, sir.
Thank you, Annie, and it's a really wonderful feeling to be back with the Kerala State Chapter webinar program. Thank you, Rajan sir, for conducting this, and really a privilege, to be part of it, and also, giving that immense, kind of opportunity for postgraduates across. Today, we have the privilege to have Dr. Diana Lim, and it's indeed, endometrial carcinomas are a common malignancy in our daily practice nowadays. We have come a long way from our histological, morphology, grading, staging, and also, what we do as typing of these tumors. Yes, we know about our problems of observer variability when it comes to high-grade endometrial carcinomas, but with personalization in medicine and with advent of molecular pathology, becomes very important that any classification is meaningful, from a prognostic and from a therapeutic relevance. And even our the Cancer Genome Atlas, which has come way back, a decade back, has really contributed a lot to the genomic basis in endometrial carcinomas. And who better to speak to us about this than Dr. Diana. Dr. Diana is the senior consultant at the National University of Health System in Singapore. She's also the director of the Molecular Oncology Center, which is a CAP-accredited lab focused on molecular diagnostics of solid tumors. Her special interest lies in gynae and molecular pathology, and she's done her FRC-PAT and FRC-PA. Apart from that, she's undergone subspecialty training in gynae pathology at the Mass General, and it's followed up with a fellowship at the Memorial. She's published several review articles, abstracts, and book chapters related to gynae and molecular pathology. She's also a contributing author to the 5th edition of the W2 classification of humans and anthrax. And Dr. Diana is going to speak to us on the changes in the 2020 WHO classification on endometrial carcinomas and also the molecular classification. Over to you, Dr. Diana. The floor is yours.
Thank you, Dr. Nambia, for the kind invitation. Let me share my screen. Okay, so thank you to the organizers for the kind invitation to speak at this meeting today. My name is Diana Lim, and I'm from Singapore. So before I start my talk, I thought I'd give you a brief introduction of where I come from. For those of you who may not be familiar, Singapore is an island nation with a population of slightly less than 5.5 million people, situated at the tip of the Malayan Peninsula. We have a mascot, which is a hybrid between a mermaid and a lion, both of which do not actually exist on the island. We have a garden, which looks like it belongs on the set of a sci-fi movie. And we perhaps have the unfortunate reputation of being the only country in the world who has banned the sale of chewing gum. So I currently practice at the National University Hospital, which is a tertiary referral hospital and an academic medical center. NUH is also the principal teaching hospital for the National University of Singapore School of Medicine. The hospital has a department of ONG with a division of gynae oncology comprising of 3 gynae oncology surgeons. And endometrial cancers are the most commonly encountered gynae malignancy in my daily practice. So gynae cancers are also the most common gynecological malignancy in Western countries, and it is the 5th most common cancer in women worldwide. It is estimated that by the year 2035, about 500,000 new cases of endometrial cancers will be diagnosed yearly. While the global obesity epidemic, together with other risk factors such as an aging population, decrease in the use of hormone replacement therapy, decreasing hysterectomy rates for benign disease, and the increased prevalence of diabetes have all contributed to an increase in the incidence of endometrial cancer. Now, different classification systems of endometrial cancers have been adopted throughout the years. This includes the Bachmann classification, which divides endometrial cancers into type 1 and type 2 tumors, and the WHO classification, which classifies tumors according to the histopathological characteristics. Now, more recently, a molecular classification of these tumors have also been proposed. In the 1980s, Bachmann proposed that endometrial cancers can be separated into two groups based on their clinical, metabolic, and endocrine characteristics. The prototypical type 1 and type 2 cancers will be the endometrioid and the serous carcinoma, respectively. Type 1 tumors associated with a hyperestrogenic state and often preceded by endometrial hyperplasia. These tumors tend to be well to moderately differentiated, show hormone receptor positivity, and have favorable clinical outcomes. In contrast, type 2 tumors are more common in non-obese women and they arise in the absence of metabolic or endocrine disturbances, usually in the background of atrophic endometrium. These tumors tend to be poorly differentiated and are often associated with a poor clinical outcome. The WHO classification, which I'm sure all of you are familiar with, classifies endometrial carcinomas into the various subtypes listed here. So in my talk today, I will touch upon the use of a binary grading system in endometrioid carcinomas, discuss the issue of synchronous endometrial and ovarian endometrioid tumors, as well as the prognostic significance of extensive lymphovascular invasion. And during the second half of my talk, I will also be discussing the various molecular subtypes which have been discovered in the recent years and how we can make use of certain surrogate markers to stratify these tumors into the molecular subtypes in clinical practice. I will touch upon the use of some immunomarkers and how to interpret these immunomarkers in serous and clear cell carcinomas, discuss the current definition of what constitutes a mixed endometrial carcinoma, and also briefly talk about some of the less commonly encountered subtypes of endometrial cancers. So as you know, pathological grading is very important for the risk stratification and management of endometrioid carcinoma. These tumors are traditionally graded using the FIGO grading system and separated into grade 1, 2, and 3 tumors based on the amount of solid non-squamous or non-morular proliferation that's present within the tumor. The presence of severe cytologic atypia in the majority of the tumor cells increases the grade by one level, but in my experience, this is not a common finding. And in instances where there is a distinct discrepancy between the architecture and the cytology, the possibility of a serous or even clear cell carcinoma should be excluded. Now, the International Society of Gynecologic Pathologists has recommended moving towards a binary grading system by considering FIGO's grade 1 and 2 tumors as low grade and grade 3 tumors to be high grade. However, for patients desiring a fertility-sparing approach, it will still continue to be necessary to distinguish between grade 1s and 2 tumors, as grade 1 tumors may be managed conservatively, whereas grade 2 tumors generally are not. The binary grading system has been shown to be equal or superior to the 3-tiered FIGO system in terms of inter-observable variability. In clinical practice, determining FIGO grade is not always that clear-cut. Some pathologists consider the growth of a microacinar growth pattern as constituting solid proliferation, although FIGO does not specifically address this. Now, for the purpose of grading, ISGIP is regarding a confluent microacinar pattern to constitute solid growth, although they admit that this is not really evidence-based. They would also consider a tumor to be FIGO grade 3 if the solid areas, which constitute more than 50% of the tumor, resembles poorly differentiated non-keratinizing squamous cell carcinoma. Not infrequently, we come across patients with low-grade endometrioid tumors present within the endometrium and the ovaries. In these instances, we often have to determine if the tumors represent synchronous primaries or metastasis from one side to the other. Patients with simultaneous involvement of the endometrium and ovary by low-grade endometrioid carcinomas often have favorable outcome, suggesting that these may represent synchronous primary lesions rather than metastatic tumors. However, recent studies have shown that such tumors are clonal in nature and probably represent metastasis from one side to the other, usually from the endometrium to the ovary. In the latest edition of the WHO, conservative management of patients with synchronous endometrial and ovarian endometrioid carcinoma should be considered when the following criteria are met. So both tumors have to be low grade. The endometrial tumor can only show superficial myometrial invasion. There should be no involvement of another site, and there should be absence of extensive lymphovasculation at any location. Lymphovascular invasion is uncommon in endometrioid carcinomas and is seen in about 5 to 15% of these tumors. They're usually associated with tumors exhibiting a microcystic, elongated, or fragmented pattern or mouth pattern of invasion and can be seen with tumors with mismatch repair deficiency. Artifacts such as the displacement of tumor cells within spaces and tissue retraction due to delayed fixation can mimic lymphovascular invasion. Displacement artifacts may result from surgical manipulation of the uterus, or it may be induced by the inappropriate grossing of a friable tumor. Artifactual displacement is more likely to occur in tumors with poor fixation or those with abundant necrosis. Clues that you may be dealing with an artifact include a discrepancy between the low stage and grade of a tumor and the extent of lymphovascular invasion, a preferential involvement of thick wall blood vessels within the outer myometrium, and the presence of both benign and malignant tissue within the blood vessels, including the presence of stromal surrounding malignant glands. But this was a case which I just received last week. This was a hysterectomy specimen performed for a low-grade endometrioid carcinoma. On microscopic examination, there were multiple foci of tumor lying within cleft-like spaces in the myometrium, reminiscent of lymphovascular invasion at low power. A higher power view of these foci shows the spaces conforming to the shape of the tumor islands, and the tumor was stained with a vascular endothelial markers, and these vessel-like spaces actually lack endothelial cell lining and represent very prominent retraction artifacts. So extensive or substantial lymphovascular invasion is defined as the presence of tumor cells in at least 5 vascular spaces. Although the presence of lymphovascular invasion itself does not upstage the tumor, extensive or substantial lymphovascular invasion has been demonstrated in several studies to be an independent prognostic factor in endometrial cancers. In my synoptic reports for endometrial cancers, not only do I comment on the presence or absence of lymphovascular invasion, I now also state the number of such foci that is present within the tumor. So why is it important to quantify the number of LVSI foci? Well, data from 2 clinical trials, the PORTEC 1 and 2 trials, have shown that the extent of lymphovascular invasion is an important risk factor for recurrence and or metastasis of this tumor. And patients having substantial lymphovascular invasion demonstrate a higher risk for distant metastasis and pelvic recurrences. The trial data also showed that patients with substantial LVSI would benefit from the use of external beam radiotherapy in order to reduce the risk of pelvic recurrences. Serous carcinomas are the second most commonly encountered endometrial carcinoma in clinical practice. These tumors are characterized by the presence of solid papillary and or glandular patterns associated with marked nuclear pleomorphism. These tumors are by default considered to be high-grade carcinomas. Well, serous intra-epithelial carcinoma is characterized by the replacement of endometrial surface or glandular epithelium by high-grade malignant cells similar to those seen in invasive serous carcinoma. These lesions can shed malignant cells and metastasize to extra-uterine site, and therefore should be considered to have metastatic potential, thus requiring the same meticulous staging as patients with typical serous carcinomas. These tumors almost always show a mutation pattern form of P53 staining and typically demonstrate diffuse staining for P16. Unlike the tubo-ovarian serous carcinomas, the endometrial serous carcinomas are less likely to show diffuse expression of WT1, but focal expression can be seen in about 30% of these tumors. So mutations in the P53 gene usually result in an all or nothing aberrant P53 staining pattern by immunohistochemistry. This is characterized by a strong and diffuse expression in at least 80% of the tumor cells, or complete absence of expressions in the tumor cells in the presence of appropriate positive internal control. Another form of aberrant staining pattern in the form of cytoplasmic staining with variable nuclear expression has also been described. But do note that wild-type P53 expression does not necessarily exclude the diagnosis of a serous carcinoma in the appropriate clinical pathological setting. It has been demonstrated that some of these cases which show wild-type expression may still harbor an underlying pathogenic P53 mutation. So in serous carcinoma, the P16 expression is typically strong and diffuse. And more recently, a now pattern of P16 staining, similar to that observed for P53 has also been seen in this tumor as a result of underlying gene deletion or methylation of the CDKN2A gene. HER2 expression and or gene amplification can be seen in more than 30% of endometrial serous carcinomas. In 2018, the results of a phase 2 clinical trial showed that the addition of an anti-HER2 agent, trastuzumab, to the standard chemotherapy regime actually prolonged the progression-free and overall survival of patients with advanced stage and recurrent HER2-positive endometrial serous carcinoma. This regime was subsequently endorsed by the NCCN a year later. So in my experience, the immunoexpression of HER2 in serous carcinoma is often associated with significant intratumoral heterogeneity, which also correlates with heterogeneity of gene expression or gene amplification by in situ hybridization techniques such as FISH. So the lack of apical membrane staining is common in HER2-positive tumors with a glandular or papillary architecture, resulting in a basolateral or lateral staining pattern. This chart shows you the HER2 staining testing algorithm for endometrial serous carcinoma based on the original clinical trial enrollment criteria. A tumor is considered to be HER2 positive if there is strong, complete, or basolateral or lateral membrane staining in more than 30% of the tumor cells, or if the FISH HER2 to Ceph17 ratio is more or equals to 2, or if the average HER2 copy number is more or equals to 6. So similar to its ovarian counterparts, clear cell carcinoma of the endometrium is a tumor which can be composed of tubulocystic, papillary, and solid growth patterns, and is composed variably of cells with polygonal, cuboidal, flat, or hobnail-like cytology, and they can have variably clear to eosinophilic cytoplasm. Immunohistochemically, these tumors can stain for HNF1 beta, nepsin A, and even Mmr. So this was a paper we published a few years ago showing that a panel of immunohistochemical markers comprising of nepsin A, HNF1 beta, ER and PR can be helpful in distinguishing endometrial clear cell carcinomas from endometrioid carcinomas, including those with clear cell changes. A subset of endometrial clear cell carcinomas can also show mutation pattern P53 staining. So that is not a feature which is unique to serous carcinoma. These tumors also have significant molecular heterogeneity and can fall into any of the 4 molecular subgroups, which we will discuss later. A mixed endometrial carcinoma is a tumor composed of 2 or more distinct histological types of endometrial cancer, where at least one component is either a serous or clear cell carcinoma. So mixed carcinomas are actually rare and do not include morphologic variants of a specific histotype. They do not include tumors with an ambiguous morphology. Endometrioid carcinoma with mucinous differentiation are not considered to be mixed carcinomas, nor are dedifferentiated endometrial carcinomas or carcinosarcomas. Well, the previous edition of the WHO uses a 5% cutoff for the non-dominant component, but this has been removed in the current edition. So where possible, immunostains should be used to support your diagnosis. It is important to document all the morphological subtypes in your histology report, along with the approximate percentage of each component, even if the component comprises less than 5% of the tumor. Mesonephric and mesonephric-like adenocarcinomas are new entities included in this 5th edition of the Blue Book. So mesonephric carcinomas are derived from mesonephric duct remnants, and these are centered on the lateral wall of the uterus where these remnants usually occur. These tumors most commonly are found in the cervix, but primary vagina and uterine corpus lesion have also been described. Mesonephric-like adenocarcinomas morphologically resembles mesonephric carcinoma, but they occur in the uterus and ovary without associated mesonephric remnants. The pathogenesis of these tumors is still unknown, and it's uncertain whether they represent mesonephric carcinomas that arise within the endometrium or ovary, or endometrioid carcinomas that is showing some form of mesonephric differentiation. This was a case we received in consultation a few months ago. The lady is a 55-year-old patient who presented with a 1-month history of foul-smelling PV discharge. So endometrial biopsy and a subsequent hysterectomy was performed at an outside hospital, and the specimens were sent to us for a second opinion. The endometrial biopsy specimen shows these fragments of tumor tissue with solid areas as well as foci of glandular structure that you can see on low power examination to be reminiscent of a endometrioid carcinoma. On higher power examination of this tumor, we see the presence of these irregular small glandular spaces containing this luminal eosinophilic material. There was no squamous or mucinous differentiation identified. The tumor cells showed relatively low-grade cytology and were quite uniform in appearance. The hysterectomy specimen contained a 3.5 cm polypoidal tumor in the anterior endometrium with some minimal myometrial invasion. Microscopic examination of the tumor shows variable architectural patterns with solid glandular and even papillary areas. So again, in certain parts of the tumor, we saw the presence of these small tubular or glandular structures with luminal eosinophilic material, whereas in other areas, there were these larger glandular spaces, some with luminal papillary projections. The cytologic atypia of this tumor cells was at most mild, and the tumor cells often showed a round ovoid nuclei. Some of the cells had nuclear clearing and even longitudinal groove mimicking the changes seen in papillary thyroid carcinomas. GATA3 expression were noted in the solid and glandular areas, and there was also focal staining of calretinine. Luminal CD10 expression was noted. The tumor cells do not express ER or PR. So based on the morphologic features and immunoprofile, a diagnosis of mesonephric-like adenocarcinoma was made. Now the tumor cells, the immunoexpression of this tumor is as follows. They can show variable expression for GATA3, TTF1, calretinine, and CD10. GATA3 has the highest sensitivity and specificity for distinguishing these tumors from endometrioid carcinomas. CD10 expression in these tumors is typically apical or luminal, as you have seen previously. They can express PAX8 and CK7, but they are typically negative for ER and PR. They also show wild-type P53 staining, and P16 expression is often this patchy mosaic pattern. So like mesonephric carcinoma, mesonephric-like adenocarcinoma often harbor activating KRAS mutations in codon 12, but they can also harbor other genetic alterations associated with Mullerian tumors, such as the PIK3CA mutation. Given that these tumors can demonstrate these activating of KRAS mutations and PIK3CA mutations, they may respond to specific targeted therapy against these pathways. Mesonephric-like adenocarcinomas have a high propensity for distant metastasis, particularly to the lung, and is associated with poor overall survival. In one reported series, the factors listed here were significantly associated with an increased risk of metastatic disease. In the current WHO classification, mucinous carcinoma encompasses tumors with gastric or gastrointestinal-like features similar to those described within the endocervix. This does not include endometrioid carcinoma with mucinous differentiation. The tumor cells usually exhibit low-grade cytologic atypia, and they show at least focal immunoexpression of one or more of gastrointestinal markers such as CDX2 or MUC6. They typically do not express ER. On the whole, these tumors exhibit aggressive clinical behavior similar to the gastric type adenocarcinomas of the cervix or the vagina. So in practice, we often rely on the use of a variety of immunostains to help classify problematic tumors. But as you know, there is significant inter-observer variation even amongst expert gynecopathologists, especially with these high-grade tumors. Thus, there is a need for a more robust or reproducible way of characterizing these lesions. So in 2013, the TCGA published a large-scale molecular analysis of more than 300 endometrial cancers. And they divided these tumors into 4 separate categories with distinct clinical, pathological, and molecular features. These are the POL mutated, the MSI hypermutated, the copy number low, and the copy number high subgroups. These molecular subgroups have been shown to have prognostic significance, with the POL mutated tumors having the best prognosis, even though they may look morphologically high grade, and the copy number high tumors having the worst outcome. So the ultra mutated endometrial carcinomas are characterized by mutations in the exonuclease domain of the POL gene, which result in proofreading dysfunction during DNA replication. These tumors have a very high mutation rate, leading to high tumor mutation burden, or high TMB. The POL exonuclease domain mutations typically occur in patients with early stage yet high-grade tumors, which are often associated with a very prominent lymphocytic infiltrate. POL tumors are associated with exceptionally favorable prognosis. The MSI, or mismatch repair deficiency group, is characterized by loss of nuclear expression in one or more mismatch repair proteins or microsatellite instability. This phenotype is most often associated with MLH1 promoter hypermethylation. Only a small percentage of these cases may be associated with Lynch syndrome. Tumors with MSI also tend to be high grade, may have an undifferentiated carcinoma component, and is associated with a prominent lymphocytic infiltrate. These tumors are potential candidates for immunomodulatory therapies. The largest molecular subgroup consists of tumors with low copy number changes. These are referred to as endometrial carcinomas with no specific molecular profile, or NSMP. They have a low TMB and they have a low copy number alterations. And this group consists mostly of grade 1 to 2 endometrioid carcinomas, which can show squamous differentiation and typically express ER and PR. The copy number high subgroup is characterized by high number of somatic copy number alterations and a low mutation rate. The majority of these tumors harbor P53 mutation, and they comprise mostly of serous carcinomas, as well as a subset of FIGO grade 3 endometrioid cancers. This group is associated with an unfavorable prognosis. So how can we apply this classification in a clinical setting? Successful translation requires methods that are easy to perform and interpret, relatively low in cost, and have a reasonably short turnaround time. In short, as my clinicians would often say, we want a test that is good, fast, and cheap. So as most pathology labs do not have the resources or budget of the TCGA, we cannot rely on the fancy techniques used in the original study. Instead, surrogate markers have been proposed to help replicate the molecular classification in routine clinical practice. So this includes sequencing for the mutations in the exonuclease domain of the POL gene, as well as a surrogate as well as microsatellite instability testing, or IHC for MMR proteins as a surrogate marker for the hypermutated group. And P53 IHC can be used as a surrogate marker to exclude the presence of a copy number high subgroup. Morphological features can sometimes provide clues that you're dealing with a POL mutation. Histologically, the POL mutated tumors usually demonstrate at least some endometrioid features, at least focally. They can tend to be high-grade tumors, and they can show ambiguous sort of morphology. They may also have increased tumor-infiltrating lymphocytes and or peritumoral lymphocytic infiltrate. There is no current immunohistochemical surrogate for POL mutation, so nucleic acid-based approaches are required to assess for POL mutational status. This may be in the form of single gene testing, such as Sanger sequencing, or a multiplex assay, such as NGS. Assays which can detect tumor mutational burden, such as the Foundation 1 assay, can also be used. It has been shown that patients or tumors with a pathogenic pole mutations can display characteristic genomic alterations, such as those highlighted here. And using this criteria, some authors have proposed a scoring system to assess these alterations, and this is known as the pole score. The pole score can be used to predict the pathogenicity of pole mutations in these tumors. Testing for mismatch repair deficiency can be performed either with the use of IHC for MMR proteins or microsatellite instability testing. Now, as you may know, MMR is dependent on the actions of several proteins which function as heterodimers. Within a cell, MLH1 dimerizes with PMS2 and MSH2 dimerizes with MSH6. MLH1 and MSH2 are the obligatory partners for their respective heterodimers. Mutations in MLH1 and MSH2 will result in degradation of the heterodimer. In contrast, mutations in MSH6 and PMS2 may not result in degradation of MLH1 and MSH2, as the function of the secondary protein may be compensated by other proteins. So Mmr Ihc consists of an assessment of the expression of 4 MMR proteins, namely MLH1, MSH2, MSH6, and PMS2. This assay shows a high concordance with the MSI assay. So a simplified 2-antibody approach using just PMS2 and MSH6 has been proposed as a cost-effective alternative, but this usually requires you to perform MLH1 and MSH2 staining in cases with any abnormal staining of PMS2 or MSH6. Now, most labs with IHC capabilities will probably be capable of performing MMR IHC, and the technique also has the added advantage of being able to identify the mutated gene compared to MSI testing. It is also able to detect MMR deficient cases that can potentially be missed by MSI testing, specifically MSH6 mutations, which tend to be associated with microsatellite stable tumors and tend to occur more frequently in the endometrium than in the colon. MMR IHC is very fixation sensitive, and poorly fixed areas typically tend to show false negative staining. This table shows you the commonly encountered loss of staining patterns of MMR proteins and their underlying associated genetic defects. So loss of MLH1 and PMS2 would most likely be due to a MLH1 promoter hypermethylation, or less commonly due to MLH1 gene mutation. Whereas a loss of MSH2 and MSH6 would be due to a defect in MSH2 or APCAM. Isolated loss in the expression of MSH6 or PMS2 would be attributed to defects in MSH2 and PMS2 respectively. This was another case which we just received recently. Again, a hysterectomy specimen for a low-grade endometrioid carcinoma with focal mucinous differentiation. The tumor cells show loss of MLH1 and PMS2 in the presence of positive internal control. The expression of MSH2 and 6 was retained, so the staining profile would likely be secondary to MLH1 promoter hypermethylation or a mutation in the MLH1 gene. Now, what are some of the issues that can occur with the interpretation and reporting of MMR IHC? Firstly, there is no standardized terminology that is used. The College of American Pathologists recommends using the term intact or loss instead of positive and negative to avoid confusion, whereas ISGIP recommends reporting staining patterns as being normal or abnormal, or defective or deficient as alternative. You may sometimes encounter cases in which both the tumor and the internal control show weak or loss of expression. This may be due to poor tissue fixation or technical issues with the IHC. So try repeating a stain either on the same or another block, or perform MSI testing to confirm your findings. As with any gene defect, there could be truncated protein showing weak or very focal expression. Such cases should not be reported as normal. The staining in tumor cells should generally be stronger than that of the internal control and be present throughout the tumor. Normal expression of the MMR proteins can sometimes be seen in the presence of a mismatch repair defect, as it is possible for a non-functional protein to show some retained antigenicity. Therefore, normal expression does not totally exclude a genetic defect, and this should be stated as a caveat in your report. MLH1 loss can show punctate nuclear staining in a minority of cases, particularly with the use of the Roche M1 antibody. Rare cases may show cytoplasmic staining. This could be due to an underlying technical defect. The stain should be reported, should be repeated, and if the results still show it to be cytoplasmic staining, the results should be reported as abnormal. Tumor progression and high mutation rates can sometimes result in the development of MMR defective subclones in any cancers. So subclonal loss could represent an underlying genetic defect, and ISGIP recommends that it should be reported as abnormal, although there is no strict definition of what constitutes a subclonal loss at this point. Another method commonly used to identify mismatch repair defect is MSI testing. Studies have shown that monoclonal markers have higher specificity and similar or better sensitivity compared to dinucleotide markers for the detection of an MSI high phenotype. In my lab, we use a commercially available Promega kit, which analyzes 5 mononucleotide microsatellite markers, and a shift in any 2 of these markers indicate an MSI high tumor. So the advantages of using MSI testing over Mmr Ihc is that it can potentially identify patients with defective DNA mismatch repair, but intact immune staining as a result of non-truncating mutations or defects in gene other than the 4 MMR proteins that are routinely tested. Disadvantages are that it's generally higher in cost, it has a longer turnaround time, and some assays actually require some form of normal tissue for comparison. So several organizations, including the WHO, ISGIP, and NCCN, currently recommends universal testing for mismatch repair deficiency in all cases of endometrial carcinomas, irrespective of the age of the patient. This is because more than 50% of female Lynch syndrome patients present with a gynecologic cancer as the sentinel malignancy, and up to 17% may not meet the Amsterdam or Bethesda criteria for Lynch syndrome screening. Diagnosing of Lynch syndrome is important because it allows for screening and prevention of cancer in patients and their relatives. Testing for mismatch repair defects by IHC or MSI methods does not directly identify patients to have Lynch syndrome because these events could be due to somatic mutations or hypermethylation. So in the absence of hypermethylation of MLH1, referral to genetic counseling is recommended to evaluate for the presence of germline mutation. And importantly, when the clinical history is highly suspicious for Lynch syndrome, genetic counseling referral is still recommended irrespective of the MMR status. Besides its use as a screening tool for Lynch syndrome, testing for mismatch repair deficiency also has other value. So these changes has prognostic value as shown by the TCGA and may be predictive of use for specialized targeted therapies such as immunotherapy. So a mismatch repair deficiency phenotype is also a feature associated with an endometrioid subtype and supports characterization of a tumor as an endometrioid carcinoma in cases with ambiguous or serous-like morphology. P53 IHC staining has been recommended as a surrogate marker to exclude the copy number high subgroup. There are four main patterns of P53 staining that have been described. The first 3 patterns seen here are termed abnormal or aberrant or mutation type, and they are strongly predictive of underlying P53 gene mutation. Now, the type of P53 staining should be reported as wild type or abnormal or aberrant, and the pattern of staining should be indicated in the pathology report. P53 staining should not be reported as positive or negative, as this kind of terminology is both confusing and ambiguous. These are examples of different types of P53 staining patterns that you may encounter. At the top left, we have a tumor showing normal wild type pattern of P53 expression with variable proportion of the tumor cells showing variable staining intensity. At the top right, we have a tumor showing overexpression of P53. Almost all the nucleus of this tumor shows strong expression of P53 compared to the much weaker staining in the internal control seen here in the center of this tumor. The bottom left shows an example of a tumor with complete absence of P53 or null pattern P53 staining in the presence of a positive internal control. And the last pattern of staining, which is also the most uncommon pattern that you may see, associated with aberrant P50, with an underlying P53 mutation, is that of a cytoplasmic expression of P53. So using the surrogate markers, which we have discussed earlier, the Vancouver group developed a molecular classifier, which they termed PROMISed, to assign patients with endometrial carcinomas to 4 molecular subgroups based on the combination of mutation and protein expression analysis. This classifier was tested on 2 separate cohorts of patients and was found to show good correlation with clinical outcomes, similar to what was observed with the original TCGA study. The group then used this classifier to assess whether molecular classification could be obtained on diagnostic endometrial specimens obtained prior to surgical staging and its concordance with molecular classification performed on the subsequent hysterectomy specimen. And they found that there was a high concordance between the biopsies and hysterectomy specimens, which even outperformed the concordance of grade and histotypes in these tumors. So potentially this would mean that pathologists may be able to test for molecular features in the endometrial biopsy or curettage samples, and this would enable earlier and more informed decision-making for both patients and the physicians. So for example, detection of a pathogenic pole mutation in a young women with otherwise high-grade looking tumor may allow the clinician to consider a more conservative approach, given that these tumors are associated with an excellent prognosis. Molecular subtyping of endometrial cancers has also been incorporated into the clinical trial setting. So for example, the PROTECT-3 is a randomized clinical trial investigating the benefit of combined adjuvant chemotherapy and radiotherapy versus radiotherapy alone for women with high-risk endometrial cancers. Using the FFPE samples from the PROTECT-3 trial participants, the authors investigated the prognostic relevance of the molecular classification and the relationship between the molecular subgroups and benefit from adjuvant therapy in these patients with high-risk endometrial cancers. So they performed immunohistochemistry for P53 and MMR protein and did DNA sequencing for POL and was able to classify the tumors into one of these 4 molecular subtypes. As you can see, there was no clear correlation between histological and molecular subtypes. For example, the grade 3 endometrioid tumors may fall into any of the 4 molecular subgroups. Similarly, the other histotypes of endometrial carcinomas have also been shown to be molecularly diverse. So results from this analysis showed that the molecular classification has a strong prognostic value in high-grade endometrial cancers, with POL mutants demonstrating an excellent prognosis, while P53 mutants were associated with the worst recurrence-free and overall survival. This data also showed that patients with P53 abnormal tumors benefited from an aggressive adjuvant regime consisting of both chemotherapy and radiotherapy, irregardless of histotype. While patients with POL mutations showed excellent outcomes in both arms of the trial, suggesting that these groups of patients do not require aggressive adjuvant therapy, irregardless of stage and histotype. So in 2020, the European Society for Gynecological Oncology, their radiotherapy and oncology, as well as the European Society of Pathology, published joint guidelines for the management of endometrial cancer. And for the first time, they incorporated the molecular classification into the risk stratification for endometrial CA. So the European guidelines propose 2 alternative approaches to stratify the risk of patients with endometrial cancers based on whether molecular classification is available or not. Essentially, all patients with stage 1 and 2 POL mutant tumors, regardless of FIGO grade, histotype, or LVSI, are included in the low-risk group. This implies that these cases would be managed by observation alone with no need for adjuvant therapy. All P53 abnormal endometrioid tumors were lumped together with the non-endometrioid carcinomas, and in the absence of myometrial invasion, these tumors were considered to be of intermediate risk, while tumors showing myometrial invasion was considered to be of high risk. For the MMR deficient and the NSMP subgroups, which have intermediate prognosis, FIGO grading, LVSI, and the depth of invasion remains to be important for risk assessment. So rarely a tumor may show the presence of 2 or even 3 molecular signatures, and it has been shown that outcomes of these tumors likely correspond to that predicted by the driver subtype. So for example, a tumor with both P53 aberrant C and POL mutation, the behavior of this tumor would most likely be that of a POL mutated tumor. However, the number of these cases reported in literature is still very low, and I think more evidence will need to be gathered before we can confidently predict the behavior of such tumors. So in summary, I've discussed some of the salient changes included in the latest edition of the WHO classification involving endometrioid and non-endometrioid carcinomas, including the use of a binary grade in endometrioid carcinomas, the issue of synchronous endometrial and ovarian tumors, and the prognostic relevance of the presence of substantial lymphovascular invasion in these tumors. I've also illustrated the different patterns of P53 and P16 staining in serous carcinomas and discussed the recommended criteria for HER2 scoring in these tumors. So the current WHO classification of female genital tract actually endorses the use of molecular classification together with the traditional clinical pathological parameters to guide clinical management and to ensure more accurate prognostication of these tumors, particularly in high-grade cancers. This can be achieved through the use of the various surrogate markers, which we have discussed previously. So in summary, POL mutant tumors are associated with excellent prognosis with no need for adjuvant therapy for patients with stage 1 or 2 tumors. The MMR defective tumors show intermediate prognosis and may respond to immunotherapy. The copy number low subgroup is heterogeneous and may be further stratified into different risk groups using other biomarkers. And the copy number high group is associated with poor prognosis, but a subset of these tumors may respond to anti-HER2 therapy. This table shows the definition of the different prognostic risk groups based on molecular classification of endometrial cancers, which can be used to guide therapeutic decisions. Universal testing for mismatch repair defect using MMR is recommended for all patients with endometrial cancers. MLH1 hypermethylation studies can be performed on tumors showing loss of MLH1 and PFS2 staining. And in the absence of hypermethylation, referral for genetic counseling is recommended to evaluate for presence of underlying germline mutation. Similarly, patients with loss of MSH2 and or MSH6 expression should also be referred for genetic counseling. So over the next few years, I believe we will see further refinement and improvement made to the molecular classification of endometrial cancers. New biomarkers may be identified which will guide prognostication and guide therapy, such as the use of CTNNB1 and ARID1A mutations to further stratify tumors within the NSMP group. There will also be more clinical trials guided by a combination of traditional clinical, pathological, and molecular risk profiles. And also, I believe there will be more trials exploring the use of targeted agents or combination regimes. So this concludes my talk for today. I thank you for your attention. I'll be happy to take questions.
Thank you, Dr. Diner, for that comprehensive, extensive coverage of all the endometrial cancers and the issues in endometrial cancer. And as we move on to molecular classifications, I think we are flooded with questions. I think with endometrial cancer is something that everyone sees around, and obviously that's the reason. I can start off with a few of them. Could I start off with the questions?
Sure.
Yeah. We have our own, speaker, Dr. Bharat, wanting to ask you on your experience on heterogeneous pattern of P53 immunostaining. What I understand, what he has mentioned is, there are sometimes areas of diffuse and areas of wild type. So in endometrial cancers, and what's been your experience on such P53 staining?
Yes, I would say in most most cases, the expression is quite clear cut. It's either it does fall into the all or nothing sort of category, but I agree there are definitely cases where I do see it's a heterogeneity in expression, and some of these I believe may be due to underlying POL mutation. So the patient may have underlying POL mutation, and then the tumor progressed and acquired somehow acquired a P53 mutation later on in some subclones, so resulting in this very heterogeneous staining pattern. So sometimes if I'm not sure, I actually will repeat the stain in another block to see whether the staining pattern is still heterogeneous or is perhaps the first slide that I'm seeing, the heterogeneous pattern may not be a real form of aberrancy that I'm staining. So repeating it may help, but definitely there are tumors with true heterogeneity in the expression, and some of these could be due to underlying POL mutation. So if the problem does not get resolved with repeated staining, I will actually just report that in that finding in my pathology report. So I actually do report the heterogeneity of P53 expression that I see sometimes. And then say I cannot be confident on whether it's clearly overexpressed or it's abnormal, it's a normal form of staining pattern.
And in the same light, when you get a P53 negativity in a serous carcinoma, how do you deal with that?
So the first thing I look for is the presence of positive internal control. If I do not see positive internal control, then there's a high chance that what I'm seeing could be a false negative staining. So again, I repeat it either on the same or different block to confirm my result. If I still do not see good P53 expression in the form of internal positive control, whether in the stroma cells or in the vascular endothelial cells, then I will say that the result is not interpretable for this case. It could be due to, like, for example, post-fixation of the tumor.
I think another question is hovering around POL mutations, and POL mutations are becoming such an important thing, In fact, much of the molecular classification actually starts with POL mutations.
Yes.
And that's one of the problems in this particular molecular classification. And and more so, it really defies, also whether you have to really look at, is morphology becoming now a redundant thing? Because with the way POL mutations are completely changing even treatment protocols. Some of the questions, are relating to the POL is on your experience with POL mutations, any particular, what is the percentage of POL mutations in general that you see around in your cases, and any particular, guideline or something while you look at POL mutation? How is that clinicians are taking to this?
The reported figures, I think international figures have been about 7 to 12% is reported in some series. But in my experience, I think in my local cohort, we have seen a lower number. But I think that could also be because we are not testing all patients. So in Singapore, we do not routinely test for POL mutations in all patients because, first of all, the patients pay for the test. So it depends on whether, there's a question of whether they can afford the mutational studies or not. So we actually try to triage, again, based on histological features. So if I have a tumor which is high grade and has some ambiguous looking features, or there is a very prominent lymphocytic infiltrate, perhaps I will state in my report to say that there's a risk or potential that this could be a POL mutant tumor, and suggest to the clinician that they may want to recommend testing. The other way the clinicians are recommending patients for POL mutational studies is if the clinical risk factors make it important for a POL mutant to be known. So for example, in a grade 1 stage 1A G1 tumor, it's not so important to know whether it's a POL mutant, because these are very low grade tumor and very low risk to begin with. And in Singapore, generally, they will not be offered adjuvant therapy anyway. So there are those where, whether knowing whether it's POL mutant will will change management. So if they are poor mutant, they may not offer them adjuvant. In those cases, the clinicians will recommend poor mutation studies.
Right. Another question which has come is regarding the Lvsi counting. The guidelines on Lvsi counting. So your impressions on that?
Okay, I must admit this has given us a lot of problem, because in the past we were just happily saying whether it was present or not present, and now we have to meticulously look through every slide and count the number of focus between, because like 4 and 5 now makes a difference, because obviously 5 falls in the category of extensive lymphovascular invasion. So the recommendation in terms of sampling is like at least 1 block per cm tumor. And then you screen through the slides to look for foci, and you're not sure whether it's a foci of LVSI, you can perform vascular endothelial staining to confirm your findings.
Right. Another thing that, among the questions that have come is, on the relevance of NGS, or, what could be a panel, because you have now HER2 testing also coming up. So what would be your panel, that you would recommend on immunohistochemistry, or for that matter, a broader panel, or would you go for some kind of gene panels, small gene panels in endometrial cancers, or how much of NGS do you do in your routine testing?
So we are still relying on single gene testing for the poor mutation studies, simply because now you can use IHC as a surrogate markers for the other subgroups, right? But if you were, for example, wanting to come out with NGS panel, I don't think I would just restrict it purely to endometrial cancers. You probably consider combining it with other more common cancer subtypes like colon and lung cancer, for example, that are common in Singapore. So if I were to come out with NGS panel now, I would incorporate other genes. I probably would not restrict it strictly for endometrial cancer. I think it would make more sense for that panel to be multi-purpose rather than just for endometrial cancers. Yeah. So I think that would be a way to make it a more cost-effective panel if you were wanting to come out with a small gene panel, but relevant genes pertinent to a few cancer subtypes rather than just one particular cancer type.
Thank you so much, Dr. Diana, for having spent your precious time with us and really disturbing you on a late evening. Thank you so much for answering all the questions and really keeping all the participants glued to listening to you.
Thank you.
Thank you so much.
Thank you.
Thanks.
Thank you, Diana. Okay.
Thank you, Dr. Diana and Ajit sir. So we're going for the last session of the day. I welcome Dr. Sadi PP to introduce the speaker for this session. Madam was a former HOD of Pathology, Government Medical College, Calicut, currently heading the Department of Pathology at KMCT Medical College, Kozhikode. Over to you, ma'am.
Good evening. Am I audible?
Yes.
The topic is mesenchymal neoplasm. We know the spectrum of mesenchymal neoplasm in the uterus also has expanded in recent years, like any other tumors or any other system tumors. Because of the advancement in the molecular techniques, it became possible to identify recurrent molecular alteration in different tumors, so that a more biologically and clinically significant classification has become possible. The aim of this molecular classification is not just an academic basis, but it also has a base on which we develop the targeted therapy for each subcategory. Today, to talk about that, we have none other than Santosh Menon, Professor of Pathology and Uro-Oncology Disease Management Group at the Memorial Center. I feel really proud to introduce Dr. Santosh Menon, our own student. Thank you, Rajan and Dr. Gani, for giving me this opportunity. Santosh belongs to the 38th batch of our Calicut Medical College. Very simple, humble, and sincere student, and still maintaining this simplicity, even now being the Professor of Pathology and Uro-Oncology Disease Management Group of Tata, having an experience for more than 18 years. His current interest areas of interest are oncopathology, mainly uro-oncopathology and gynec-oncopathology and immunohistochemistry. To mention few of his achievements, he is in the editorial board of WHO classification for male genitourinary tumors 2021, and he is the secretary of Society of Genitourinary Pathologists India, Urology Cancer Foundation, an external reviewer for ESDO on cervical cancer management, as well as an external reviewer for the quality indicator of cervical cancer registry, the reviewer of endometrial carcinoma surgery quality indicator, and he is a nominated member for Genitourinary Pathology Society USA, more than 75 publications in his credit. He is an ex-sub-editor of Indian Journal of Cancer, reviewer of several international journals. Over to you, Santosh.
Thank you very much, Sati madam, for that very, very kind introduction. And it's heartening to see you, even though it's virtual. Am I audible, Dr. Ani?
Yes, yes.
Yes, sir.
You are audible.
It's great to see Dr. Rajan sir also. Hi, Rajan sir. How are you? I hope you are all doing very well.
Yes.
There, I would have loved to be a part of a physical meeting so that I could have met you all physically, but then the times are such that we still are meeting virtually. So hope to see you all soon sometimes. I would like to thank Rajan sir, Dr. Ani, and the Kerala chapter for having me here. And the topic for me today is on mesenchymal tumors, and Sati madam has already introduced a lot of things on that. Let me see which is this. Is my screen visible?
Yes, yes, visible.
Yeah. So my topic for today is mesenchymal tumors of uterus. I've put in added statement that some of them are mundane, the routine leiomyomas, which we call mundane. Some are controversial, some are old, and some are new. So we will go through this. The intent of this lecture is to target PG students, including second, third year PG students, to most importantly make a diagnosis, reach a diagnosis. And then there are certain tumors which, like Sati madam has already said, you cannot do without molecular these days. And there is some little initiation into molecular of these tumors. There are certain very rare tumors which none of us has ever seen probably, and those certain pictures I have taken from a couple of journals like Histopathology for completion's sake. So with it, I would just go on to the picture of this WHO female genital tumors. And if you look at the list of tumors, mesenchymal tumors, we have the smooth muscle tumors and the endometrial stroma and related tumors. That's a basic category. And most common, if you look at smooth muscle, are the uterine leiomyomas. There is a category of intravenous leiomyoma, which is self-explanatory. The controversial and difficult category of smooth muscle tumor of uncertain malignant potential, which is the stump. We have a very enigmatic category of metastasizing leiomyoma. I've seen only one case of that up till now. And then the dangerous and very, very aggressive uterine Lvsi sarcomas. The endometrial stromal sarcomas we'll go on to later, but basically they are divided into endometrial stromal nodules, low grade and high grade. And high grade again have different categories which are characterized by molecular statements now. So this is again a blow up of the same to look at the same categories of different classification of mesenchymal tumors of uterus. If you look at the basic thing, the benign or the uncertain mesenchymal tumors of uterus, I've used uncertain because the stump is definitely uncertain category, whereas the leiomyoma, intravenous leiomyoma, metastases are generally sort of put under the category of benign mesenchymal tumors. So I have a lot of pictures. It is basically intended to for the PGs. The classical leiomyoma, the mundane day-to-day routine, we see several of them. They are very circumscribed tumors. You have this pink-looking tumor. It can be looking very blue when it is cellular, and that's when you call it cellular leiomyoma. Important thing is to look at them. They are very circumscribed. They generally do not invade the myometrium, and that's an important feature you need to pick up on morphology. Again, short and long fascicles, bland-looking spindle cells. When you see such things under low power in the microscope, you are almost definitely sure you're dealing with a leiomyoma. You may go to high power, and you should make it a habit to go to higher power to look at the mitotic activity. Sometimes these leiomas can have rip roaring mitosis at places. Always remember, that a grossing of such specimens is very important, all mesenchymal tumors, because most of the differential diagnosis borderline cases are decided based on necrosis and mitosis, which I'll be coming and alluding later on. And that's the basic understanding, that whenever you see spindle tumor, before calling it a benign thing, you have to look at higher power and look for mitotic activity. Certain leiomyomas may have characteristic this staghorn kind of vessels and this nodular appearance with edematous areas, which are alveolar kind of edema, you can say. These are seen in what is now recognized as FH deficient leiomyomas or fumarate hydratase deficient leiomyomas. And we need to keep an eye open, although they form only 1% of leiomyomas. They may occur in a vast country, in a big country like us. We may come across these tumors, and that needs to be taken into consideration. I have pulled out this list from the WHO book. These are the several leiomyomas which you may diagnose, but remember, all of them are benign leiomyomas, so their behavior is benign, and you need to pick them up. Generally, when you are struggling with giving a name to this, you open your WHO book and you try to put them into these categories. A couple of things I just want to check is apoplectic Leo Myoma. So some tumors, especially during history of progesterone, and can have a lot of areas of hemorrhage, zonation phenomena. They can have a lot of fibrin, and they may look like necrosis, and this may be misdiagnosed sometimes as leiomyosarcoma. So that needs to be kept in mind. You need to get the history from the patient, from the gynecologist, whether the patient has been treated with long-standing progesterone, and that can cause these kind of infarction and zonation phenomena, and that should be picked up and not labeled as a malignant tumor. Leiomyoma bizarre nuclei, a dangerous looking tumor. I'll show you some pictures. But again, if you stick to the basics of looking at mitosis and necrosis and only the nuclei bizarre, that's when you diagnose. What is spoken about cellular leiomyoma? Then there are the other categories of lipoleiomyoma, myxoid leiomyoma, and very rare cotyledonoid and diffuse. The cotyledon can be dissecting. There can be small nodules of leiomyoma which are going into the myometrium, but they are very smooth in contour and they look like little kind of placenta kind of appearance of these leiomyomas. I have had the experience of seeing only one case of this leiomyoma. This is a beautiful picture of a lipoleiomyoma. You can see the fat within these spindle cells. They look beautiful. There is some little myxoid change in the stroma, but this is a beautiful looking tumor of a lipoleiomyoma. Again, pictures to show you lipoleiomyoma. This is what we were talking about, bizarre looking leiomyoma. You can see how the bizarrity can really stump you and cause problems. So the idea is these things are not uncommon. When you look at an andalopar, you are totally foxed and you think that you're dealing with a high-grade malignant tumor. But again, malignancy in a smooth muscle tumor is based on a constellation of features which we will come to soon. So like I said, when you're dealing with the category of stump, atypical leiomyoma, bizarre leiomyoma, the conundrum, it's a big conundrum, and we really get stumped when we see this. It is just like spotting a wildlife from a distance. So you are standing at a distance, you are seeing a four-legged animal. You have to look whether it has got hooves, whether it has got horns, whether does it have claws or paws, and does it have stripes? And if you can see the stripes, is it black and white or yellow? And then you can tell whether it is a zebra versus a tiger. So that's the understanding. You go step by step when you see a leiomyoma. When you see a spindle tumor, when you see a smooth muscle tumor, you go step by step. Don't miss out on anything. And this is one paper written by my colleague, Dr. Kedar Deodhar, in IJPM long back. He studied 21 cases of stump. And mind you, these are really, really gray zone in smooth muscle tumors. And most of the cases which we have come across in medical legal cases, litigation, belong to category of stump versus leiomyosarcoma. So that's why I am again and again reiterating the fact that it is extremely important to look at very, very basic things like cellularity, ATP and pleomorphism, mitosis, atypical mitosis, coagulative tumor necrosis. So I think this is the most important slide as far as the whole presentation is concerned, because these tumors are dicey. Stump versus leiomyosarcoma versus other categories of leiomyoma. That's when you really can go wrong and make mistakes and land up in medical legal issues. You have to stick to the basics of looking at pleomorphism, mitosis, and obviously the coagulative tumor necrosis. Other important parameters are obviously the matrix or the background. Is it myxoid? Is it epithelioid or whatever it is? And those are the criteria. And strictly adhere to the mitotic count criteria. Coagulative tumor necrosis. everybody sitting in the audience, including the PGs and the senior pathologists, will agree that coagulative tumor necrosis is a nightmare. It's always difficult to pick this up. The best thing which we can do and understand is that it's an abrupt transition from viable cells to necrotic cells, and that's when without an intersposed zone of granulation tissue. So it's a very abrupt from viable to non-viable. That's when we are looking at coagulative tumor necrosis. There would be ghost outlines of cells, and even those ghost cells, we can make out that they are very pleomorphic kind of cells, and that's when we really understand that this is, and take it as coagulative tumor necrosis. The other type of necrosis is the Hyaline necrosis, which we call, or non-coagulative type of necrosis. It may sometimes show not show that much collagen deposition, and there may be some abrupt transition, and that's when the dilemma and difficulties arise, because this is a very, very important criteria when we are looking at smooth muscle tumors. So picking up CTCN is of India, and then there is the individual cell tumor necrosis, sometimes which we see. Many people believe that this is an infarction type of necrosis, but there are certain other people who say that whenever you see this kind of necrosis, you should take more samples from the tumor, so that you have adequately sampled and ruled out a CTCN in the individual. So how do you classify a stump? I think this is an old one given by Bell et al., who said that it's not working. Right. So this they may be atypical leiomyoma with low risk of recurrence, atypical leiomyoma but with limited experience, and then smooth muscle tumor of low malignant potential. There are several names to this kind of tumor which we say, but remember, most of the times these are the tumors which have bizarre nuclei but don't have the adequate amount of necrosis. So this is again a picture of a stump which I taken from the article by Dr. Kedar, and this is showing you very, very bizarre nuclei, little epithelial appearing cells. But again, these does not have mitosis. The necrosis may be single cell, but not the typical CTCN which you see. So this is the WHO criteria of diagnosing uterine smooth muscle tumors of uncertain malignant potential. First and foremost, you look at the necrosis, whether it is absent or present. If necrosis is present, then there should definitely not be any atypia, and the mitosis should be very less. So that's when you call it stump. And if the mitosis, if the necrosis is absent, then there is a provision that there may be moderate to severe atypia. But again, the mitotic rate is generally considered to be less in this. So this table, whenever you are in doubt, please open the book again, go through this, because this is difficult to memorize and difficult to find. And now the WHO has included the criteria of per millimeter square instead of mitosis per 10 hectopascal. That has caused even more problems. People have to relearn things, and people have to standardize this across the board, and that's going to add a little. But then that is an aim to have a standardized criteria of mitotic activity throughout the whole of the WHO. So this is a classical picture to show CTCN. You have tumor cells which are perivascularly preserved here, and then you have necrosis, which is very, very abrupt at this junction between the tumor and the. So this is what is called as coagulative tumor cell necrosis. Very abrupt transition from a perithelial preserved tumor to a completely necrotic area, and then you may see a lot of debris along this tumor also. Again, a higher power to show how the viable tumor is suddenly getting into a necrotic area, and that is important. In contrast, this is a more hyalinized kind of area. You have a gradual transition. You have some very preserved nuclei in between, and there is hyalinized areas. So this is not to be called as a coagulative tumor necrosis. Sometimes when the patient has been given progesterones, you can have myxoid looking necrosis. Sometimes the patient has a large fibroid, there is gel embolization. So this is a picture of a gel, which is gel embolized tumor, completely showing necrotic areas, and you should have this history with you when you are looking at leiomyomas with this kind of necrosis. So it's important to know the backgrounds about these patients. So the leiomyomas are benign, but then you have watershed areas. When you see atypia, when you see more mitotically active areas, you have to take more sections, and we have to all think about and look at the basics of mitosis, necrosis, and atypia. And based on that, we have to put the patient, categorize the patient either as a category of some leiomyoma or a stump, or then call it a leiomyosarcoma. Coming to uterine sarcomas, they are rare tumors again, and they're a heterogeneous group of mesenchymal tumors. Uterus is the most common primary site, and the less common sites, some of them Bharat has already alluded to, are the vulva and vagina. What are the different kinds of uterine sarcomas? The most primary ones are the leiomyosarcoma, endometrial stromal sarcoma, and the adenosarcoma. Rest are the sarcomas which can occur very rarely in the uterus are rhabdomyosarcoma, Ewing's, and synovial sarcomas. which we see rarely in the uterine tract. Before we go into the actual diagnosis of that, I just want to allude that the figure staging of sarcoma is a little different from the endometrial cancers, and it is basically based on the size of the tumor in the stage 1A, 1B, and we have to accurately measure the tumor size if we have a resected specimen of a sarcoma, because based on the 5 centimeter cutoff, they are staged into 1A and 1B. For the other types of sarcomas, like your MPNSTs and rhabdomyosarcomas, you have the FNC LCC grading system, which is used similar to what we used in the soft tissue sarcomas. So what is uterine LMS? It's a malignant neoplasm of pure smooth muscle differentiation. It is the most common uterine sarcoma, and it typically occurs in postmenopausal women. This is again from the WHO criteria. You have a conventional uterine leiomyosarcoma, you have an epithelioid leiomyosarcoma, and a myxoid leiomyosarcoma. It is again difficult to learn these by heart. Whenever you encounter a possibility of leiomyosarcoma, please open your book, please look at the ATPR, please look at the necrosis, and please look at the mitotic activity. And based on this criteria, and mind you, mitotic activity is something which is very, very subjective again. Sometimes there is a lot of difficulty in labeling what is mitosis, and it is a good practice to show your colleagues, to show your friends, and show your fellow mates whether they agree with this is a mitotic count, and have a cross count with people, because this is an area where mistakes occur in this situation. So these are the criteria. Again, coming back to the very important thing to diagnose leiomyosarcoma, again, you fall back onto the very, very basic, which is ATPR mitosis and coagulative tumor necrosis. So some pictures to show. So this is a photograph, micro photograph, to show that this is mitosis, probably this is mitosis. But then there are certain things you're not sure of this one. You're not sure of what is happening here. And that is one the problem occurs. If I show it to first year JR, this figure, they will count maybe 20 mitosis in this. So mitosis in a smooth muscle tumor is a problem. There is a lot of degenerative changes. Leiomyomas, leiomyosarcomas, smooth muscle tumors are hormonally responsive tumors. They are in various stages of activity in there, and the nucleus may look from very, very crisp to very, very degenerate kind of appearance. And that's very important, not to call and label a degenerating nuclei, degenerated nuclei as a mitotic activity, and that needs to be carefully picked up. Again, to show pictures of what may be called as mitosis, probably this one, not sure of this one, but then there are other smudgy kind of nuclei here and here and here, which some may call it mitotic activity, and inexperienced I would call it mitotic. So it's important to pick up basic mitotic activity. Again, picture to show a very strange looking mitosis here, but again, you have some degeneration here, some degeneration here, some degeneration here, which you're not sure and should not be labeled. So you have to take up and count the typical mitotic activity. Again, pictures to show that. Pictures to show a typical coagulative tumor necrosis, abrupt transition from a spindle tumor, viable to a non-viable area, completely necrotic. In comparison, this is a more hyaline kind of an area, which should not be called, not to be no necrosis. Not necrosis, and that's important. It's a very hyalinized area and not to be labeled as a problem. Comes in this when we have limited sections and we have this kind of necrosis, and we are not sure whether some procedure has been done previously to the patient, like a embolization and all, then we really start struggling with this. Although we can see the outlines and silhouettes of these, and this is when we try to say that this necrosis is not sure, it is indeterminate, and if it is accompanied by a bizarre looking smooth muscle tumor, we would probably label this as a stump and put the patient on close follow-up. So some more pictures: pink looking tumors, blue looking tumors, variable mitotic activity. You have to look at various fields and go according to count. Sometimes these, even at low power, there may be some very apoptotic looking cells, and you may label them as mitosis. You have to go to high power to count the mitosis, and not at low power. Show very, very bizarre looking leiomyosarcoma. Again, looking at areas, you can have very bland looking cells in between very, very pleomorphic looking cells in this tumor. Again, single cell necrosis merging onto areas of typical necrosis with lot of tumor debris, and this would be counted as CTCN. Again, pictures to show what a typical coagulative tumor necrosis looks like, and this is how you should label this tumor as possibly a leiomyosarcoma based on the ATPR and the presence of necrosis. In contrast, this is what a hyaline kind of an area looks like, or hyaline necrosis looks like. A very important feature which many of us don't is an infiltrative border, a tumor which is infiltrating the myometrium, showing a lot of bizarre nuclear mitosis, is with smooth muscle tumor marker positive, has to be labeled as a Leo sarcoma. So this infiltrative borders and destruction of the myometrium is an important criteria to label anything as malignant, whether it's a myxoid Leo sarcoma or a typical conventional Leo sarcoma. So you have to take sections of the tumor with the adjacent myometrium, and that's important. Unfortunately, the problem in diagnosis of Leo sarcoma is always that these tumors preoperative radiology are called as fibroids, and they are morcellated. Some of them are not morcellated in a bag, and that's when the problem starts. There is spillover into the peritoneum, and that's when the patient has to bear the consequences of this. Thankfully, most of the gynecologists laparoscopically are now using morcellator with a bag, and they morcellate the tumor in a bag, so the chances of spillage are less in this tumor. This is a Desmin positive. This is Caldesmon, which are typically seen in this. P16 is a good marker. A good 60-70% of leiomyosarcomas would be positive nicely for P16, diffuse nuclear and cytoplasmic positivity, and we do routinely employ this when we are dealing with leiomyosarcomas. That was conventional. When you have more epithelioid, rounded, and polygonal cells, pink-looking cytoplasm, you have to think of epithelioid leiomyosarcomas. The criteria are different. Go back to the criteria, look at it, look at the mitotic rate of 4/10 hyperfields, count it, and then you have a diagnosis of epithelioid leiomyosarcoma. Higher power to show the same. Again, epithelioid looking cells. A caveat here is whenever you look at epithelioid looking, say leiomyosarcoma, query leiomyosarcoma, always think of a pecoma also, because pecoma can have this morphology, and you have to employ in your panel, in addition to the smooth muscle markers, you have to employ HMB45 to pick pecoma, diagnose of pecoma. A more epithelioid looking leiomyosarcoma with a lot of ATP, a little myxoid background. And this is a myxoid leiomyosarcoma. Generally, it's not so cellular. It is less cellular, but then there may be some cellular areas, some areas which may be typical of a conventional leiomyosarcoma, but the predominant has to be a myxoid to call it a myxoid lega. A general conventional leiomyosarcoma may also have myxoid areas, and then it should not be called as a myxoid leiomyosarcoma. More epithelioid admixed with little myxoid areas infiltrating the myometrium in this picture. Word about molecular pathology. It has not come into routine practice in leiomyosarcoma, but I think the important markers are P53 and MED12, which can be seen in substantial percentage of leiomyosarcomas. Currently, targetable treatment in leiomyosarcomas are not that advanced, and it is a general chemotherapy which is given to these patients, and most of these patients have a very poor outcome. Even if they're early stage tumors, they would the risk of recurrence is very, very high in leiomyosarcomas. Most of the times they present with metastasis. In a country like ours, they are late presentations are seen. Coming quickly to other sarcomas like adenosarcomas, like the name says, the tumor is basically a low grade to high grade sarcoma, which is intimately admixed with benign glandular epithelium. And here I would like to show a paper by Dr. Bharat, who published this in IGPM again, 19 adenosarcomas, and he showed a spectrum of this with low grade, this kind of phylloid kind of appearance, which you can see in adenosarcomas with low grade component. But then there are high grade components of the sarcoma, but the glands remain benign and the gland look benign, and they are part of the tumor, they're part and parcel of the tumor. But these are again very, very rare tumors, and we get to see them very rarely. Coming to the newer categories of endometrial stromal sarcoma, the classification of endometrial stromal sarcoma. Do I stop here for a minute, Dr. Rajan sir and Sadi madam? Any questions on this before I move ahead? Hello, Rajan sir, any Sadi madam, any questions? Anybody?
Yeah, let me see it. Is there any cutoff for using MIP index in differentiating leiomyoma and leiomyosarcoma?
No, madam. Life would have been easy if you had cutoffs for K67. Life would have been easy, not only in gynae, but across the board in pathology, if there were MIB cutoffs. So, but yeah, leiomyosarcoma would not have a low MIB index, that's for sure. So, unfortunately, the low definition of low is different for different people.
What is your experience with P16 in leiomyosarcoma? Always
Not always, madam, but a good 60-70% would be positive in these.
Okay.
We do.
What about the progesterone effect of progesterone?
Yes. So ER and PR are usually done. We do it about 40-50% would be ER positive in these. And that is important because especially in a metastatic setting of leiomyosarcomas, when they don't have any option of any other chemotherapy, they would put these on antiestrogens, these patients.
No, pre-operative progesterone, sometimes they give, no? So
Uh,
what is the effect of the stomach?
Pre-operative progesterone for leiomyosarcoma. The problem with leiomyosarcoma, like
Even leiomyoma.
Leiomyoma, yes. Yeah. So that's what causes a lot of issues, madam. It causes necrosis, it causes apoplectic changes, and that needs to be kept in mind. So whenever we have a typical leiomyoma, but showing strange areas like hemorrhage and fibrin and that kind of necrosis, we do ask, although we don't get typically leiomyomas in our practice because we are a pure cancer center, but we do, sometimes it does land up our table and we ask for history of whether preoperatively progesterone was given to the GnRH and all those were given to the patient.
Nowadays, it's a real problem. Sometimes it's
Yes.
even inflammation.
Exactly.
And
yes, ma'am. Yes.
Okay, no more questions. Santosh, you can
Okay, sure. So coming to endometrial stromal sarcomas, the classification is again endometrial stromal nodule, which is extremely rare. I'll not be going into that in detail. The commonest one is the low-grade endometrial stromal sarcoma, a very, very enchanting tumor again. And then we have the high-grade endometrial stromal sarcoma, which are the YWHA and the BCOR rearranged ones. So this is the latest WHO, and this has been recognized as separate entities. And we have to use an extended panel of immunohistochemistry as well as molecular to categorically diagnose these two categories. Coming to low-grade endometrial stromal sarcomas, they are very indolent tumors. They have a favorable prognosis. The issue with them is they are characterized by very late recurrences. I'm sure anybody who's practiced long enough in pathology would have seen low-grade ESS recurring after 15 years, 18 years, 20 years. So that's a very strange kind of a tumor which can have very late occurrences, and thus the patient has to be under a long-term follow-up. The 5 years survival is good, and even in a metastatic setting, when it comes back, they are generally hormonally manipulated drugs, manipulable drugs, and that's an important part of low-grade ESS. The classic feature is this tongue-like infiltration into myometrium with this very classical arterioles which are seen in this tumor, very uniformly distributed arterioles generally in a classical case, and this tongue-like projections into the myometrium called as permeation of the myometrium. The correct term to use is permeation of the myometrium, and that's how they look like. This is an old picture showing a very blue-looking tumor invading the permeating the myometrium. Again, the very classical picture of arterioles which are interspersed throughout this blue-looking tumor. So the cells look like endometrial stroma, but then it's a complete tumor. All areas are full of these blue-looking tumor with interspersed arterioles. The interface of the tumor with the myometrium is permeative, tongue-like, and that's a characteristic feature of these low-grade endometrial stromal sarcoma. They invariably have lymphovascular emboli again throughout the myometrium, in the vessels, in the lymph nodes. You can have metastasis, and this is how they look. In this, they can take up the shape of the vessel, a beautiful emboli of this low-grade endometrial stromal sarcoma, which is seen in the myometrium. They can have different morphologies. They can be less blue-looking, have more prominent vessels. They can have less prominent vessels with more blue-looking areas, where a differential you should entertain is of a high-grade ESS, because a high-grade ESS can have a biphasic or biphasic areas of low-grade looking areas and a high-grade looking areas. So that's important. Then you have a pink-looking tumor with, again, that vascularity is still there. And then there you have pseudo-papillary kind of, or pseudo cystic. In there may be cystic spaces with these projections which can occur in this tumor throughout. Sometimes there may be smooth muscle stroma which may look hyalinized within them, and then there is a smooth muscle differentiation which is characteristically seen as a starburst phenomena within this endometrial stromal tumor, and those are the different kind of variations which you can have. This was in a very old study. We did study 84 cases of low-grade ESS, and we found that uterus is the most common site, although it can occur anywhere ranging from cervix to ovary in this tumor. The important point about low-grade ESS, another thing, is the morphology is generally preserved. You don't have too much variability in the classical morphology. So we did a thesis of 75 cases later on recently. And out of that 75 cases, 72 had a very classical morphology of ESS. And only in 3 cases, we had a little sex cord-like areas and all that stuff, which is not very common. And I'm not touching upon them. That's why. I'll take this high-grade ESS as a case, probably. This is a 37-year-old female who presented with menorrhagia. MRI showed a polyp with adenomyosis, and then she had a lot of deposits throughout the peritoneum and adnexae and hepatic and all that. So this was how she presented. Then we have this microscopic picture. These were slides which were sent from outside as referral. You can see this again, tongue-like projections which are going into myometrium, which made us think that this is probably a strange-looking ESS, a little bluish myxoid-looking tumor which is going into the myometrium. Higher power to show that these are bland-looking spindle cells, more or less pretty much monomorphic, very less pleomorphism, but the background matrix is a little myxoid in nature. There was mitotic activity, not rip-roaring, but frequent mitosis was seen. And then there were very few areas of necrosis, which was characteristically seen in this tumor. This is a tumor which was strongly diffusely positive for BCOR and cyclin D1. And we did think of a BCOR rearranged tumor. And that brings us to this table that whenever you are dealing with endometrial stromal tumors, especially the YWHA tumors and the BCOR tumors, you have to do this battery of tests. CD10 is a good marker for low-grade endometrial stromal sarcoma. It can come across all high grades also positive. ERPR is generally strongly positive in low-grade ESS. Can be variable in both YWHA as well as BCOR mutated high-grade ESS. Important markers to pick up high-grade are cyclin D1 and BCOR. So if these two markers are positive, we are most likely dealing with a high-grade endometrial stromal sarcoma, and the confirmation does require a molecular testing for FISH for YWHA rearrangement or a BCOR sequencing, which is done for these patients. So this is again a paper from Modern Pathology long back in 2018. About 17 cases of a new variant, new high-grade endometrial stromal sarcoma, the ZEC3H7B BCOR high-grade endometrial stromal sarcomas. These are again, these can be very, very myxoid in nature. So the idea is, how do you pick these high-grade endometrial? These are generally myxoid, and their differential is a myxoid leiomyosarcoma, but then they are more cellular compared to a myxoid leiomyosarcoma, and that's when you would want to do a BCOR and a cyclin D1 to pick these up. There is positive staining for cyclin D1, CD10, and BCOR may be positive in 80%. Again, you have to confirm them with molecular testing. These are of two types. One is the fused one, and the other one is the BCOR internal tandem duplication. We are currently not doing these tests in our department, but a couple of patients have gone outside and got this done from various different other molecular labs outside. So coming to the other high-grade endometrial stromal sarcoma, this was one of the first papers on YWHA endometrial stromal sarcomas. They are again supposedly high-grade in their nature, and they are characterized by the presence of this fusion, YWHA NUT M2A fusion, which is characteristic of this. Again, the IHC profile is of cyclin D1 positivity. Mind you, they can be positive for c-KIT and CD56, and that needs to be kept in mind that these tumors have got a variable profile of IHC. Classically described, this is one of our own cases, shows this kind of a strange pattern, which you may probably think is like a low grade, in the sense they've got bland areas like this, spindle and interspersed areas of this more pink areas. And then there is sudden abrupt transition to a round cell tumor like areas with edematous areas. So that's the classical combination picture of what you see in a YWHA translocated high-grade ESS. They can have a variable mitosis, but they are generally diffusely and strongly positive for cyclin D1. Mind you, they can be positive for BCOR also, and that's why any tumor which is BCOR and cyclin D1 positive has to go for a FISH for YWHA, and if it's YW rearranged, then you call it a YWHA rearranged high-grade ESS. Again, you can see that the low-grade areas may not show that strong positivity compared to the round cell-looking areas in the high-grade ESS, which is strongly and diffusely positive for cyclin D1. And that's the catch, and that's how you probably start picking up these tumors. We did a FISH for this, and it was very nicely and clearly showing translocation of the YWHA tumor. Another YWHA translocated tumor, very blue-looking tumor, and these sudden areas of necrosis are pretty characteristic of this tumor. Again, a blue looking tumor in this case, round cell areas, thin vessels around them. Some may even start thinking of Ewing sarcoma. But then generally the look is of an endometrial stromal kind of a appearance. And then you have mitosis, you have cyclin D positive and B Corp positive. And that's when you think and make a diagnosis of high-grade ESS and ask for molecular testing. A strange tumor which we came across, a rare tumor in the uterus, again, which can be confused with high-grade sarcomas, is an inflammatory myofibroblastic tumor. You can see the myxoid and the very tissue culture-like appearance of these spindle cells, which are following each other like a shoal of fish appearance, and that's a very characteristic. You can see that the inflammatory cells are interspersed throughout this. This was desmin positive, SMA, ALK was positive, and we confirmed it with fish calc. That finishes a lot of category of endometrial sarcoma. Whatever is left is dumped into an undifferentiated endometrial sarcoma. When we are not able to characterize the tumor, we are not able to fit. Thankfully, this category of undifferentiated endometrial sarcomas is diminishing, because many of them with the translocation studies are either categorized as high-grade ESS, BCOR type, or the YWHA type. And then we have other categories which are coming up. So some other newly described sarcomas, I'll just take up a case. This was again a lady who was referred from Delhi, 62-year-old lady. Again, presented with a large tumor in the fundus of the uterus with multiple enlarged lymph nodes in the iotacoval and paraiotic region. She underwent exploratory laparotomy and TH-BSO, and we got 3 blocks referred from Delhi. And this was how the tumor, it was almost completely destroying the whole of the myometrium. It was a large tumor with nodal metastasis. And this is the picture. It looks blue under the microscope. And even at this power, you can see areas of these small areas of necrosis and breakdown. And then there were again large areas of geographic necrosis in this tumor. Blue looking tumor. Again, you can see that they are sort of small nests, very thin capillary kind of things, very prominent nuclei. Even at this power, you can make out. But otherwise, they look pretty monomorphic. They don't have that pleomorphism of the nucleus, no size shape variation. Very again disappearance and some breakdown in between. The stroma is there. At this power, probably you can appreciate they have a little rhabdoid morphology in these tumor cells. More higher power to show clearly that many of them have got eccentrically placed nuclei and a pink rhabdoid looking cytoplasm, which is very characteristically seen in this picture across the board. And then there is areas of necrosis. There were some areas of myxoid. So we wondered what kind of tumor is this? Higher power to show the very prominent nuclei and the cytoplasm of these cells. The differential diagnosis we entertained were endometrial stromal sarcoma, non-Hodgkin lymphoma was a possibility. Some people even thought of myeloid tumors in this. Then there was undifferentiated uterine sarcoma and undifferentiated carcinoma, which we thought of. These are the IHCs. A1, A3 was negative. Cyclin D1 was rather strongly positive. So we thought we are dealing with an endometrial stromal sarcoma in this. SMA was focally, this is a picture from a focal area, which is for positive. CD10, very focally positive. INA1 was retained in this tumor very nicely. Desmin, HMB45, CD30, MUM1. So these were different. This went across the board of different disease management groups, from gynae to lymphomas to everybody saw this case because it was a dicey case. And finally, we landed upon this. We did a BRG1 or SMARC-A4, and we can see that the tumor cells are dead negative. So there is loss of BRG1, loss of SMARC-A4, and that's how you arrive at a diagnosis of SMARC-A4 deficient endometrial stromal sarcoma. These are extremely rare tumors. This patient was affording, they went for next generation sequencing and found that there was loss of SMARC-A4. These are newer tumors, and the more and more we pick up these tumors, the less the undifferentiated category is going to be. So the undifferentiated category is going to diminish as more and more molecular tumors are, more and more molecularly defined tumors are described in this category of tumors. This is the case which we happen to publish. This is the first case from India which we published. This patient was given pazopanib, but unfortunately the patient died within 6 months. She had an initial good response to pazopanib, but finally she succumbed to her disease. I think I'll skip these ones. Quickly going into the last uterine tumor, probably. This is a 20-year-old female. I think I've shown it in one of my slide seminars. This was a large mass. Patient referred from Calcutta with large mass in the abdomen, bilateral ovaries not seen separately. Because she was 20 years, they did an AFP because it's important to rule out a germ cell tumor. They did LDH and they did all these markers. And because the LDH was raised, the possibility of dysgerminum was entertained. She was given 3 cycles of BEP. Somebody saw it again. They called it a lymphoma and was given 1 cycle of CHOP. So this is the problem and issues which we face in day-to-day practice. Somebody just based on the markers without a tissue diagnosis started treating and gave the patient treatment of germ cell tumor. When the patient came to us, we saw this core biopsy from the tumor. It's a long core, almost resemble prostate cores. Lot of smooth muscle bundles here, but then there is something different looking area here. So this is how the lesion looked very foamy. There was a lot of pigment in this area because the patient had been given chemotherapy. We thought it's all dead. Again, very bland monomorphic looking cells, different from the smooth muscle bundles, probably of the myometrium. Again, you can see the wispy looking cytoplasm, eosinophilic cytoplasm. Some of them have got clear cells. Again, very bland. The nuclei look pretty bland, pretty monomorphic throughout the lesion. And some areas had very clear kind of appearance. And if you can appreciate, there is slight pigment. We thought it was all hemosiderin, possibly because of the chemotherapy patient has received. More areas to show you pigment. And this is a stain. So this came as HMB45 positive, strongly and diffusely. You can see that how it is nicely positive in the cells. Desmin was negative. The normal myometrium or the smooth muscle bundles are positive. Desmin negative. The tumor or the lesion is negative. This is another stain which we did, which is TFE3, which is strongly positive in this tumor cells. Very dark. It's almost looking black, so strongly and diffusely positive. SNZ was negative. So this is again a mesenchymal tumor of uterus. It's a malignant pecoma, which is TFE3 positive. A quick wrap up of this. These are again challenging cases which we come across rarely in the uterine tract. They have been described. And the female genital tract accounts for nearly 25% of pecoma solved body. But again, if you look at it, the commonest site of pecoma in the gynae tract is the uterine body. The importance is that the TFE gene rearranged pecomas are targeted differently. There are certain other targets like crizotinib, which can be tested in these tumors. I don't want to go into the details of this. I think I'll skip this. The issue is that in this case, we had a very foamy and clear appearance, and we thought it was all histiocytic cells post chemotherapy. But we need to keep in mind that it's a large tumor, a misdiagnosed tumor previously, and we have to judicially use the IHCs to arrive at such diagnosis. I think I will stop, Sati madam, here. Maybe I think it's too late to continue this because the rest is all some new terminologies which people need to be aware of, like NTRK fusion cervical sarcomas, which are there. And these are pictures from the WHO which I've taken, and some other tumors which are coming up. These are purely molecularly defined tumors, and without doing molecular, we cannot categorically diagnose these tumors, like NTRK tumors and COL1A1 tumors, which are fibrosarcoma-like tumors. The rare uterosac tumors which resemble sex cord tumors in the uterus. And I think I'll just skip this. To summarize, basically, if you look at sarcomas, Lyomai sarcoma is the commonest. I think we stick to the basics. Sadi madam, you'll agree with me. The PGs need to understand that atypia, mitotic count, and CTN. I think this is the most important thing. And mind you, this is one of the commonest cause of litigation which I've seen in gynae practice. Stump versus leiomyoma versus Lyomai sarcoma. Low-grade endometrial stromal sarcoma, very characteristic histology, hormonally amenable sarcoma. High-grade sarcomas are now of two types, the YWH mutated and the BCOR rearranged. And now the undifferentiated sarcomas will continue to shrink as more entities like SMARCA4 deficient sarcomas are described. And some of the sarcomas may have targetable therapies in future. We still don't have many targetable therapies, but I'm sure in the next decade, this is going to be a big boom in the treatment of uterine sarcomas. I would like to thank my colleagues, Dr. Bharat and Dr. Kedar, my gynae clinical colleagues. You learn a lot from clinical colleagues. They push you to do better, come out with new tests and new things. And obviously, I want to thank my residents and patients. Thank you so much.
Thank you, Santosh, for beautifully illustrating the real challenge in reporting smooth muscle tumors. Few more question will take. One is, what is your experience with P53 in leiomyosarcoma?
We generally don't do P53 in all leiomyosarcomas. If it's a straightforward leiomyosarcoma, we would not do a P53 in such tumors. But then if we're really at crossroads sometimes of diagnosing P53 leiomyosarcomas, doing P53 probably would take us towards a leiomyosarcoma because it's a mutated tumor. But generally, my experience with doing P53 on non-leiomyosarcoma is very limited. We don't do it on leiomyosarcomas.
Have you got a combination of endometrial stromal sarcoma and leiomyosarcoma?
No, madam. I don't remember coming across such a case. Seriously.
Another question is, how well should we sample when we get a laparoscopic myometry specimen? How many bits should we sample?
Sorry, I didn't get the question, madam.
How well should we sample when we get a laparoscopic myometry specimen?
So we are talking about Marcellated specimen, I think. That's what we are saying. So that's what I said. The issue of morcellation was a big problem about a decade back when people, the gynecologists were morcellating and there was spillage into the abdominal cavity. And later on, it was picked up as a leiomyosarcoma or a endometrial stromal sarcoma. These days, they put the tumor in the bag and they morcellate within the bag in most of the cases. And that is an important point. It's a difficult question to answer in the sense that how many sections do you take from a typical leiomyoma? So you have taken 5-7 sections. It looks like a very classical leiomyoma. Do you go and submit the entire morcellated specimen? The answer is no. You don't submit the entire morcellated specimen.
Leiomyoma with bland morphology having irregular margin, what should we call it, sir?
It's a difficult question, ma'am. I was expecting all such questions. Leiomyoma classical with a little undulating margins, I would not put it into anything. I would still call it a leiomyoma.
If it is well inside the uterus.
Yes.
And there is okay. What is P16 positive in non-gynec LMS?
Yeah, I think so. Many of the LMS of non-gynae are also P16 positive. It has nothing to do with HPV actually.
If hemorrhage and infarction are seen in leiomyoma, in the absence of history of progesterone therapy, we call it stump.
We have to be sure that the necrosis is at least a CTCN. So that is the importance of picking up CTCN. If you have a leiomyoma with CTCN, you would probably take more sections to ascertain the type of necrosis. You take more sections to look at if there are areas of which are frankly atypical. And that's when you really look, and you have to be careful in such cases. The idea of making this present in is there's no single answer. The answer is stick to the basics of taking more sections, stick to the basics of counting the mitosis, stick to the basics of looking at picking up the micronecrosis. If you're not sure, I have to definitely discuss it with Bharat and Kedar sir always when I'm suspecting that this is a borderline tumor, because the treatment, the prognosis is so different between a leiomyosarcomas are one of the worst tumors in the human body.
Nowadays, we see many large endometrial polyp, 8 to 10 centimeter in size, postmenopausal patients with benign-looking glands embedded in abundant fibrosarcoma. Since WHO has removed adenofibroma entity, now what will we label this as? I
think we'll have to ask WHO only that.
Is it
so basically, we are talking of something benign entity. We are talking of benign. Yeah.
Adenomyoma is there, but
adenomyoma is there, ma'am. Adenomyoma is there. Yeah, we still call atypical polypoidal adenomas. They are very well known, and they are known to involve the myometrium a little bit.
Have you seen epithelioid fibrosarcoma in female genital?
No, I haven't seen. Maybe Bharat has seen epithelioid fibrosarcoma.
Senile endometrial stoma has hyperchromatic.
Yeah, Bharat, you want to add something?
Yeah.
No, I just said I haven't seen epithelioid fibrosarcoma. Is it, madam, sclerosing epithelioid fibrosarcoma in the female genital tract? I haven't seen either.
Then, nice case. The endometrial stromal sarcoma case you showed with rhabdoid morphology similar to this, I recently got one. Okay.
Yeah, it must be SMARC A4. You should get a BRG1 done in BRG1 done.
Any more question? Anything I left, Annie?
You are muted.
Rajan sir, any questions?
Annie is
I'm
muted.
not seeing anything.
Oh, sorry. There is one senile endometrial stroma with hyperchromatic cells, compactly arranged but without mitosis. Is it normal histology?
I don't know the answer to this. Senile endometrial stoma. I don't think I have ever called something like that. So, Annie, the thing is, when we are encountering difficult lesions, the basic idea to convey to the clinician is benign versus malignant. That's a very extremely important for them. And if you're not able to, struggling with lesions, we are doing several IHCs, reaching nowhere, we at least try to tell them what kind of malignancy it is likely and what grade of the malignancy is likely. That's important for practice.
You get CD10 positivity even in Leo Myoma.
Yes, madam. CD10 is somehow losing its credibility. A lot of it comes in so many tumors.
What about Desmond and endometrial stroma?
Endometrial stomal sarcoma generally would not be positive, but focally these all can come here and there. All SMA and positivity is very well known in endometrial
Do you
stoma.
think it's more specific? Caltosoma or?
Caldesmon is specific. Smooth muscle marker, caldesmon is specific.
So if we have any doubt, it's better to do a caldesmon or SMA, or should we do both?
Generally, if you are not resource constrained, you would like to do both in that setting.
Okay. So one basic doubt, if we have multiple leiomyomas in a uterus, you will have a classical type, then you might even have a lipo-leiomyoma type. How do you name it in a report?
I would put everything as benign. That's first important thing. Most important thing is. So we can give all kind of descriptions for our fun, and but the clinician is going to ask you only one question: is there anything which is atypical there?
Okay.
Or it's atypical.
We'll wind up. Thank you, Santosh. Thank you very much.
Thank you, Santosh.
Rajan sir, thank you so much. It's so good to see you.
Yeah.
Thank you so much. Thank you. Hope to see you all soon.
Yeah,
sometime.
sure.
Yeah. Thank you so much. Thank you, Sadi madam. Thank you, Annie.
Thank you, sir.
Thank you, Indu. Dr. Indu is here, I think. Yeah, Dr. Indu, I am not seen her here. I mean, her camera is off.
Indu was here.
Okay.
She's here, I think.
Hi, Dr. Indu. Hello, hi. I haven't seen you. You are the main organizer, and so thank you for kindly inviting me. Thank you.
I was just coordinating. Yeah, thank you.
Thank you so much. Thank you.
Dr. Preeti also here.
Dr. Preeti is also here. Yeah. Thank you, everyone. Thank you so much. Have a good night and a happy weekend and 75th Freedom Independence Day. Have a long weekend. Thank you.
Thanks, Dr. Preeti. Thanks, Dr. Indu. Very nice meeting everybody.
Thank you.
Same here.
Thank you, Bharat.
Hi.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, Bharat, for sticking and
Yeah.
pitching in with mesenchymal tumors. This is your fault.
I just can't resist that, And thanks to Dr. Nambiar also. Dr. Nambiar is there. I can
Dr.
see
Nambiar
Dr. Mathur also.
Achha,
It's
there.
wonderful to see everybody,
Very good.
although virtual. Thank you.
Thank you so much. Thank you.
Thank you all. Thank you, Bharat sir, for answering most of the questions in the QA section.
Yes, I like that. So I was just, Santosh, you were asking for questions. Just look into the chat box. I was just typing throughout. And that's what I like every time. There is such an amazing audience with wonderful questions. I've had always, wonderful time answering and interacting, even though virtual.
Yes.
But it's amazing.
Yes.
Thank you.
Thank you so much.
Thank you.
Have a safe night. Yeah.
Bye.
Good night. Bye-bye.
Bye-bye.
Good night.
Thank you all for joining.
This is the end of the first evening. And we will start tomorrow sharp at 5:30 p.m. Tomorrow there are 4 sessions. Start by 5:30 and 4 sessions will be there.
Okay.
Bye.
Okay, thank you.
Good night.
Good night. Bye-bye.
Good night. Good night. Bye-bye.
Good night.
Good night.
Good night. Good night. Good night. Bye.
Riddhi.
Hello, sir. Am I audible, sir?
Yeah, you are audible.
I was just checking my audio.
Today, this is the first one, second one. Huh?
Second one.
It's at 6:30, right?
Okay, sir. It is the second one. Initially, it was the third one. The second one is, madam is not coming.
Yeah, second one is actually the
Radhika madam's talk.
Indu is the
Indu is moderating. And Radhika madam is okay, no? She's well.
She's okay.
She's okay.
I think so, Preeti.
So I think Kedar's talk will be the third one, and it is at 7:30.
Yeah.
Okay.
Start by 7:30.
It will be there.
Okay.
Everything went well today.
Yeah, it's a little bit actually with some minutes.
So we are on time. Yeah, we are
So-
actually within time. Everybody finished on time. Actually, all the questions also.
Also went.
Yeah.
Yeah.
They're all professional speakers. That is why.
That's right.
Yeah.
Okay, so see you tomorrow. Good night.
Good night. Thank you, ma'am.
Good night. Bye.
Good night.